So we're going to talk a little bit more about the specialty gases that we kind of touched base on in the first PowerPoint. Not anything crazy for detail, but just a little bit more. So nitric oxide, again, this is going to be a treatment of hypoxia caused by pulmonary hypertension in neonates. The big takeaway for you guys here is that you need to know that it's a pulmonary vasodilator. You need to know that it treats pulmonary hypertension in neonates. And essentially that's kind of the big information chunk that you need for that. Heliox, second to hydrogen, it's the lightest gas. It must be mixed with oxygen. Why? It has to be mixed with oxygen because straight helium does not support life. So if you gave someone pure helium, they would die. So that's why. It's used to reduce the work of breathing in a severe airway obstruction. Why? And this kind of explains what we've got for that. It's a low density gas, which means less pressure is required to move it in larger airways. So if you have bronchospasm to an extreme degree, you have a lot of inflammation, having that low density gas with a low driving pressure, a more laminar flow, you're going to be able to kind of navigate your way through those obstructions. I don't want to say all the time we give it with a non-rebreather because we also give it with a blender too, but essentially you want to give it with a mask. It definitely, if you're going to go low flow device, it is usually a non-rebreather that we give it. But again, also a blender with a mask. The whole reason that you want to make sure it's a mask is you're really trying to make sure that that patient is getting the heliox and that they're not pulling in any room air. You need to have an oxygen analyzer in line at all times to make sure that both gases are being delivered to the patient. And again, this is just to really reinforce helium does not support life. And if you do not have oxygen coming in, your patient is going to be in trouble very quickly. You should see the work of breathing decrease when you start heliox because that less pressure that's needed to move the gas in the airways should hopefully be helping that patient to start to ventilate and be able to slow their work of breathing. Helium kind of takes the place of nitrogen. Again, it's a light, small gas, and it basically just makes it a much smaller pressure to get that gas into the airways. It helps with large airway obstruction. Some of the side effects is it can make a very high-pitched voice. If you guys have ever inhaled helium balloons, I'm sure you're familiar with this. And the other one is it can decrease the effectiveness of a cough. Obviously, if somebody needs heliox, we're not really super concerned about their cough in that moment. But over time, it can become an issue if you have basically this lower density gas in your lungs. It can make it harder to form the pressure you need for an effective cough. This is never really going to be an issue because usually this is an emergent use item, but it's just one of the side effects to know. Indications for heliox, we talked about that severe post-extubation stridor. And what that is if you think about the upper airway being very swollen from like potentially a traumatic intubation or any injuries up there, but enough that it's so swollen that the airway is being obstructed and airflow can't get through. People who have very acute severe asthma exacerbations or asthma attacks that are coming in that are very difficult to ventilate. Severe croup. Croup is also an upper airway swelling. It's particularly in young kids, usually less than 2 years old. And it can get so severe that heliox has been used. I've definitely been in that situation. And then a very severe COPD exacerbation. You could end up using heliox, all when you're thinking about inflammation and bronchospasm blocking airflow. The big thing that kind of gets complicated with heliox is that our Thorpe tubes or our flow meters are made for oxygen gas delivery. We don't actually have a specific flow meter for heliox, okay? So because of that, we do use the oxygen flow meter, but we have to modify it. So if you're looking at the total flow that your patient is going to get, you have to use these conversion factors. So if you have your patient on the 70-30 mixture, your ratio is 1.6. And if you have them on the 80-20, it's 1.8. Okay, you're going to need to memorize these numbers. Okay, this is definitely something you guys are going to be tested on when you start doing your tank duration calculations. So what does that mean? If your flow meter reads 10 liters per minute, so if you have a flow meter plugged into the wall set at 10 liters per minute on 70-30 heliox, the actual flow is really 16 liters per minute, because you're going to take that 10 and you're going to multiply it by this 1.6 conversion factor, okay? And that means that you're actually getting 16 liters per minute. And this is just how we compensate for the fact that we don't have a heliox flow meter. If you have a flow meter that reads 10 on an 80-20 tank, what is the actual flow? Again, you're going to take that 10 that is set and you're going to multiply it by the 1.8, and that's just this conversion factor, and you get 18 liters per minute, okay? So this is just because we do not have a specific flow meter for heliox, okay? We only have an oxygen flow meter, so this is a conversion factor to compensate for that. Nitric oxide, the FDA approved it for use with neonates, treatment of persistent pulmonary hypertension. This is kind of where it explains how it enters the ventilated alveoli, and it really relaxes those pulmonary blood vessels to allow blood flow to get into the lungs so that that baby can start to ventilate properly. It reduces the VQ mismatch. So this is kind of a picture of what it does. So if you have the inhaled nitric gets into the alveoli, it diffuses into those pulmonary blood vessels, and it causes that nice relaxation or vasodilation. Here is where it's not getting in, and that pulmonary vessel is not open enough, and that blood is not able to go through gas exchange. So this is why we use it. If a neonate has pulmonary hypertension, we really want to relax that blood vessel, reduce that pressure, and really allow for that unoxygenated blood to go from the right side of the heart into the lungs where it can get oxygen. The other thing we're going to talk about really briefly is hyperbaric oxygen therapy. We touched on this a little bit in cardiopulm as well. So administration of oxygen at greater than 1 atmosphere is what you use it for. So most hyperbaric chambers deliver at atmospheres of 2 to 3. This is just kind of showing you guys back to your alveolar air equation, what that looks like if you start to double or triple the atmospheres of oxygen pressure. And I can kind of show you, this is what the math looks like here. Kind of reminding you guys of the terms of hyperoxemia or hyperoxia, which is high O2 in the blood or high O2 at the tissue level. So if you have a PaO2 of greater than 100, it's hyperoxemia. If you were going to put that on a blood gas, just kind of reminding you of those terms. So hyperbaric oxygen can be used for bubble reduction. What I'm talking about there is if you guys have ever heard of decompression sickness or having air embolism because of that. So when divers dive down really, really low, if they don't come up slowly and kind of in stages, if they come up too quickly, the nitrogen will actually come out of their blood too quickly, and it creates a lot of air emboli. So the way that we treat the decompression sickness is they'll put divers into a hyperbaric chamber to put that pressure on them to kind of force that nitrogen back in their blood, hopefully get rid of those air emboli. And that has to do with Boyle's law, not a law that you guys have to know, just kind of knowing that that's what it's related to. Hyperoxygenation of blood and tissue. So other reasons that you can use a hyperbaric chamber is to improve immune function, improve wound healing. So when you're thinking about severe burn patients or patients that have a lot of tissue damage, this is a way for them to directly diffuse oxygen into the tissues if there's capillary damage where maybe that perfusion has been compromised. And then the treatment of carbon monoxide poisoning, which we talked about a decent amount in cardiopulmonary. You guys do not need to memorize these times, but basically this just kind of illustrates how the amount of time it would take to get carbon monoxide off the hemoglobin at various pressures. It obviously decreases quite a bit quicker when you're in the hyperbaric chamber, but not something that you have to memorize. So understanding these are some of the indications that we use hyperbaric oxygen chambers for is basically all I'm looking for that. That does it for that PowerPoint. There's really not a ton of detail that you guys need to know on the specialty gases. Just want you to be essentially familiar with what I covered on the PowerPoints. It's going to be pretty basic from an examination standpoint.